Of Palm. It is my delight, my honor, my privilege to introduce Dr. Kotzenek. You know, his biography is impressive, so I'll only give you the highlights. Otherwise, most of this lecture could be done reading his bio. I will just simply say he's a professor of psychiatry at UCSD, director of the Center for Criminality and Addiction Research, Training, and Application. He's the director of the International Addiction Technology Transfer Center in Ukraine. He's also vice president of the International Consortium of Universities on Drug Demand Reduction. He has had multiple advanced training and has been at various different institutions. What may be interesting to this crowd is between 2013 and 2016, he served as the director of prevention, treatment, and rehabilitation at the United Nations Office on Drug and Crime in Vienna. So please give it up for Dr. Kotzenek.
Good morning. All right. Okay, thank you, Yoshi. Thank you, guys. I have a lot to say. We have very short time, so let's go straight into the conversation. I really want to have a conversation with you rather than lecture. People don't learn much from lecturing. But people learn much more from the emotional experiences and conversations. So today we will talk about motivational interviewing. This will be just a brief lecture. So if your expectation is that you will be able to do motivational interviewing at the end of the lecture, it's highly unlikely. But at least you will get some understanding what motivational interviewing is, what it is not, and how you can use it should you decide to use it. Okay, let's start with kind of common sense statement. I presume you would agree, even that early in your medical education, that working effectively, providing treatment to patients with acute and particularly chronic conditions is impossible without changing patient's behavior, right? If you have a patient with diabetes, even if the patient responds beautifully to insulin or medication, but the patient is 260 pounds, eats crap every day, and doesn't measure blood sugar, doesn't exercise, I mean, the patient is likely to die anyway. So there is a lot of behavioral things. Okay, this is something that is pretty common sense. No surprises, you agree with that. Well, the question is, the really $10 million question is why people don't change. Because it looks like what we are seeing every day is are behaviors that go against common sense. Because I would think for somebody who just got his or her first heart attack, that would be the perfect reason to quit smoking, right? I would think when a woman found she's pregnant, that would be the perfect reason to start paying attention to diet, medications, visiting physicians. Common sense tells me that somebody with broken relationship being fired because of the drinking, that would be perfect reason to at least to consider quitting drinking, right? And in many cases, it does work, but in most cases, unfortunately, it doesn't. People continue doing what they're doing, even despite, obviously, the problems that this behavior presents. And the big question is why? Why even facing the adverse results of some behavior or some problematic results is still not enough for people to change their behavior, typically, for most people. And there are lots of explanation models. We have tried to answer this question for decades. And there are quite a few models, quite a few answers answering this question, why people don't change. Many people believe out there, some of you probably believe too, that people don't change simply because they don't know they have a problem, meaning the knowledge is missing, or they don't know how to change the problem, how to address the problem, so the skills are missing. And there is a pretty common belief that people don't change simply because they don't care, particularly if you look at the criminal justice environments. They don't care. So they have knowledge, they have skills, but they don't have any emotions attached to that. Folks, if these answers to the question why people do not change that easily are true, I have a good news for you. And the good news is you don't need my lecture at all. Because the solutions are very simple. If the knowledge is missing, give people knowledge, that should do it, right? Get a bunch of people. I'm an addiction psychiatrist by training. I work with people with drug and alcohol problems. Well, get a group of people with heroin dependence. Tell them how bad it is to use heroin. That should do it, right? If Skills are missing. Well, give people skills. Tell people what to do to quit smoking. That will definitely, right? You just gave them skills. If people don't change simply because they don't care, well, scare them. Make them uncomfortable. Tell them, if you don't do this medication, you are going to die in 2 months, okay? That will scare them. That should definitely do it, right? We have done it, folks. We have done it for many years. And we all know how ineffective those strategies are. So, now let's discuss. Let's talk again. This is my older son when he was younger. Now he's older. He is sitting on this branch considering jumping. A part of him wants to jump. Might be fun, but a part of him says, oh, no, that's pretty scary, okay? And these are my boys when they were younger. You see, they're jumping, they're flying, they're even having fun. Think about it. Something conceptually, cognitively has changed between these two periods of time. From very clear hesitation, should I or I should not, to actually action. I'm doing it, and I'm not just doing that, I'm enjoying it. This is what the ambivalence is like, and you will understand. You don't know what ambivalence means. Ambivalence means having two contradictory thoughts about the same thing. Should I take the medication, or maybe I should avoid it? This is the medication that most likely I will have to take for the rest of my life. That doesn't look like a good idea. Okay, these are normal processes of making decisions. Ambivalence is exactly the material that motivational interviewing works with. That's why it's so important to talk about ambivalence. Most of the patients, particularly patients with chronic conditions you will be treating in a couple of years, will be patients with significant ambivalence, more or less, but they will all be ambivalent. Should I do it or I should not? Should I consider something else? This is a normal human behavior. What is important here, folks, is to differentiate, to distinguish between ambivalence and resistance. Ambivalence is not a symptom of anything. It's a normal human response to a problem to solve. It's normal. People are ambivalent by default. Should I do this or should I do that? And there are variations of different thinking processes. So ambivalence, in fact, is something that reflects my relationship with the problem that I need to solve. That's what ambivalence is. Resistance is a reflection of my relationship with you as a care provider. Do you understand the difference? Let me say it again. Ambivalence is a reflection of my relationship with the issue that I'm dealing with, I'm struggling with. That's what ambivalence is. If I'm a care provider and I start putting pressure on you, you will become defensive. And that will be converted into resistance. Resistance is a reflection of my relationship with you as a care provider. It takes two to resist. Let me give you an analogy here. Do you use GPS in your cars? Okay, at least you're familiar with this device. So you got into your car. You dial the address. This is your choice. You're telling this device, this is the place I want to go. It's your choice. Now you're driving. What is happening behaviorally in terms of the relationship between you and this electronic machine? Does it talk a lot? Usually not. But what does it do? It actually monitors your behavior every second. It monitors your driving every second. And at some point, this device, electronic device, will tell you in 500 feet, make a left on Lincoln Avenue. Okay? For whatever reason, you said, okay, no, I'm not doing that. I know a better way. Road work there, whatever. And instead of making a left, you continue straight. Okay? It happens. Does this device get emotional? Does it tell you I said left stupid? No. But what does it do? You just sent a message to this electronic machine that you're resisting the instruction. You're not following the instruction. This device will immediately register that, will change the strategy, will recalculate the strategy, and it will still continue working with you, helping you to get to the point that you said, this was your choice, you said you want to be, okay? This, in fact, is the essence of at least the spirit of motivational interviewing. No matter how many mistakes or resistances you will show to me, I will still working with you, I will register it, I will change my strategy. Because the resistance, when your patient becomes defensive or resistant, this is actually a good sign. This is a sign telling you, do not do it. Change your direction, change your strategy, do something else. Because the patient actually tells you with the behavior that really resembles resistance, the patient will tell you, don't do it. Let's define motivational interviewing. Motivational interviewing is a collaborative, patient-centered, and directive communication style. This is more than just a bunch of skills or a bunch of technicalities. This is a different communication style that, in fact, assists patients to make decisions and to address the typical, very common problem of ambivalence, particularly in patients with chronic conditions. This is a different way of being with another human being. It's not just a set of skills. Skills are important, but this is a different way of being with another human, respecting the people's authority, respecting the people's autonomy, respecting the patient's ability to make choices and the right to make choices, and not assuming that you are experts in people's lives. You will become doctors in a couple of years. You will have a bunch of certificates on your wall. Does it make you experts in people's lives? No. It makes you experts in symptoms, syndromes, differential diagnosis, using assessment tools, assessment devices, treatments. That's what you will have expertise in, definitely. Who is the expert in the patient's life? The patient, okay? Who is the expert in your life? You. You are with yourself all the time. You have your internal dialogue all the time. So all our professorships and faculty appointments and MD degrees, wonderful, but they don't make us experts in people's life. So from the perspective of motivational interviewing as a collaborative and communication style, more than just a bunch of techniques, this is something important to remember. The patient is the one who will make decisions. We are helping people, but we don't make decisions for them. We are working with people, helping them to make decisions. Okay. A couple of assumptions of motivational interviewing. First, I told you ambivalence is normal. Being hesitant is normal. This is not a symptom of any disease, not a symptom of any pathology. It's a normal human behavior. The second thing, what we know from the science, many, many years of science, human motivation to do or not to do things is extremely dynamic, extremely fluid. It changes in minutes, very quickly, much quicker than you think. And it greatly depends on the interaction style between you and your patient. Even if you disagree with the patient, if you get invited to somebody's house for dinner for the first time, and you go there and you're for the first time in this house, you don't tell people how to rearrange the furniture, right? Even if it looks ugly. There must be a rationale for them to do it this way. I will approach it with curiosity, with interest, with the attempt to understand what is the source of it, where is it coming from? Because there must be a reason for people to do it this way. That's pretty much the spirit of motivational interviewing. I want you to watch something. Very brief interaction.
Okay, so we've talked about your labs, and you seem to have a good grasp of that. And we've talked about the different options for medicines. And I think you'll agree that the last option we talked about is the best way to go in terms of the financial cost of it and the side effect profile. And so I'd like to just go ahead and write you the prescription.
I'm not quite ready for that, if it's okay. I'm just not comfortable yet. Oh. I'm still not convinced. I'm not sure I want to do this. I mean, this is like a big step for me. And I want to know, are there alternatives, for example?
George, we've been through this. We've talked about the alternatives, and
yeah, but the alternatives were all sort of like Western medicine. I mean, is there like Eastern medicine I could use?
You've been on the internet again, haven't you?
Yeah, I have, and it's a world out there.
Yeah. Well, it's a big, confusing world, and I'm glad you came here, because really you could spend a lot of money and a lot of time out there and not get what you need. We've talked about your lab values, and we've talked about the benefits of taking this medicine, and as we've weighed out the costs versus the benefits, it seems really clear to me.
Okay, let me just ask, without being too sensitive here, should I ask for a second opinion? Will that make a difference?
You can ask for a second, third, and fourth opinion. They're all going to tell you the same thing. It's not subtle. I mean, at this point, the numbers are high, and the reasons to take medicine are clear.
I guess maybe the thing that I'm not making clear is, for myself, is just the whole idea of spending the rest of my life stuck on a medicine. I mean, I watched my parents go down that road, and it just was one medicine after another, and there they sat, and next thing I knew, it was just constantly running to and from the pharmacy, and I'm really not too excited about that for myself.
Well, I don't blame you for not being excited about that picture, but the alternative picture, I think, is a lot less exciting. And if it takes a pill to keep you alive and relatively healthy as long as your parents have been, I think that pill is probably the option for you.
Well, let me try something else. Is there something I'm not making clear about? Is there something I should be thinking about before I take this step?
Thinking isn't going to lower your cholesterol, unfortunately.
So I'm stuck.
Well, you're not stuck.
Okay, guys, it's pretty clear. What is happening between these two people? It feels like a wrestling match, okay? They're wrestling. If you think from the purely factual perspective, purely science perspective, everything that this physician said is accurate. He didn't say anything wrong. But the style, this interaction communication with a clearly very ambivalent patient, and the patient is ambivalent for a reason. Starting this medication, people need to think about it. The style actually makes it very unlikely that this patient will actually start medication, right? We don't know. It's just a matter of likelihood. From the factual perspective, everything that the doctor said is correct. But these are two people who are wrestling with each other. And let me ask you, whose agenda is in the middle of the conversation? The doctor's agenda. The doctor is trying to use his authority to prove the patient that the patient is wrong, and the doctor is right because he is the expert, and probably he is an expert in cholesterol treatment, probably. And yet they're still wrestling. Let's watch the same two people discussing the same issue, but this time the physician is using a different strategy.
And believe it or not, you're not the first guy that's told me his wife made him come in to talk about this stuff.
I don't understand. Why are they so into this medicine stuff?
I don't know. I wonder if they're worried about you.
That, when stop to think about it, I suppose. There's nobody else that can change the lights in the ceiling. Yeah. Well, here I am. What do I have to do?
Well, I'm hoping that we don't need to talk about it in terms of what you have to do. I'm hoping that from our discussion before about your cholesterol and the role that medicine might play in lowering your cholesterol, that you can make an informed decision about your treatment options, and we can go from there.
But I got to tell you, my head swims when I think of all the options.
Yeah.
I mean, an informed decision is one thing. You get this much information. You probably already know. I checked out the internet, and it's just like, whoa. I could lay out in a cornfield with a cone hat on, and it would maybe lower my cholesterol, they say.
There's a million options out there.
Well, so where do I go? Should I seek a second opinion?
Yeah. Well, let's see what we can do in here today, and then you'll know that at any point in time you can seek further opinions and consultation if you think that'll make it easier.
I don't want to make it sound like I don't trust you.
Okay.
And I do. You've been good so far. But this is a big decision on my part.
It is.
And it's sort of terrifying. It's sort of like I'm becoming mortal.
Yeah.
I don't like that.
No, I hear you. It's scary to think about things that might shorten your life, and that's really what we're talking about here. And the high cholesterol, as we've said, is a pretty important risk factor for pretty serious pretty serious disease, and that's why we're talking about serious treatment options. Like you said, the medicine's not fun. It's not fun to think about having to take a medicine for a long time or even maybe for the rest of your life. And I wouldn't want to suggest that as a treatment option if I didn't think it might be helpful for you. But like you said, there are lots of other options. Let's pick an arbitrary number. Let me have you tell me just briefly about the 3 options that you're thinking about right now.
The cornfield with the aluminum cone cap?
Yeah, let's
No.
keep that on the list.
Exercise.
Okay.
Diet.
Uh-huh.
And more exercise.
Okay. So exercise seems like a really good option for you.
Yeah, I need it. I could use it. It'd be good.
Yeah.
If I worked out twice as much, would it help?
I think it certainly would help. And I don't think you'd find a doctor in this office, and you certainly didn't find one here today, that's going to discourage you from doing exercise. I'd love to talk to you more, and I've got some information that might be helpful for you about the types of exercise that you could do that would be most helpful. And even if you end up taking the medicine, I think you should seriously consider doing that exercise as part of your treatment plan.
But you still think that medicine should go along with it?
From what we've seen thus far, the medicine seems like an important part of the treatment plan. I'm not going to be taking the medicine. You would be taking the medicine. And so my job today is to make sure that I've answered all the questions that you have, so that if in fact I do write this prescription, we have a good sense that you'll...
Okay, you see the difference now? Now the doctor is using some skills. The doctor is listening. The doctor is empathetic. You know what empathy means? Empathy means the ability to do 2 things. First, to realize the source of the patient's thoughts, emotions, or actions. So I understand where it's coming from. And secondly, convey back to the patient your understanding, usually through reflections. That's what empathy is. You may completely disagree with the patient. This is totally irrelevant whether you agree or disagree. You are still empathetic. You're trying to understand what is the source of all of it, where all of this is coming from, and then you have some material to work with. Because as we said already, the material for motivational interviewing is exactly the ambivalence. Is helping. If the person is not ambivalent, if the person is doing remember, motivational interviewing is not a panacea for every situation. If you see your child running across the traffic, it's not a good time for motivational interviewing. Let's use common sense. Or if you have a patient 25 years in alcohol dependency recovery, doing fine, not drinking, not relapsing, what's the point of bringing back the ambivalence? What is not that good about being sober? Doesn't make sense. Okay? So exactly with the patients who are hesitant, ambivalent, this is the strategy that through research, I missed a 0 here, over 3,000 randomized clinical trials of the effectiveness of motivational interviewing compared to traditional approach, do it or else, or here is what you got to do, okay? Across different problem areas, drug and alcohol, eating disorders, medication adherence, exercise, diabetes treatment particularly, lots of different studies, randomized clinical trials on the effectiveness of MI in criminal justice settings. They all show that the MI with ambivalent people is by far more effective than traditional, here is what you got to do approach. All right. So this is about the fundamental spirit of MI, what we call it. Respect for autonomy, respect for people's ability and right to make choices for themselves, and just working through the ambivalence, listening very carefully to what the patient has to say. There are 4 fundamental practical skills in the motivational interviewing. If you really want to practice MI with your patients, and you will have to, I'm not telling you what you will have to do, you will decide for yourself. But if, as physicians, in a couple of years you will start seeing patients independently, and you will be seeing patients with chronic conditions, all of them will be ambivalent, then you will need to decide for yourself what style you will be using to be more effective with the patient, not to prove your point, but to be more effective with the patient. If you want to do that, these are the 4 skills, and you will need to build mastery in all of these 4 skills. We call them ORs. This is not a sequence, this is not a level of importance, no, just for the acronym sake, we call them ORs. Open-ended questions, affirmations, reflections, and summaries. And you will need to build mastery in all 4 of them. Because if you just use one, it will be like or two, it will be like rowing with one oar. You will be going in circles. You're not going anywhere. Okay? These are the skills. I will explain you what does it mean. Open-ended questions. You know what's the difference between open-ended and closed-ended questions. One thing that I want to tell you, I've heard it many times that open-ended questions are good, closed-ended questions are bad. This is not true. All of these questions are good, they just serve different purposes. Closed-ended questions have nothing to do with motivation, but they're fact-finding questions, and you need to find some facts. Open-ended questions, they give the patient the opportunity to come up with a narrative. There is a whole set of so-called, I call them dead questions. Dead questions. Why don't you? Why couldn't you? Why didn't you? The only thing that you will get as a result of this type of asking questions, people will become defensive and very resistant. So if you want to get rid of your boyfriend or girlfriend, start asking dead questions. That will do it in 5 minutes, believe me. It will be very quickly. Plus, if you are sarcastic on top of that, that will absolutely guarantee you will get rid of this relationship in 5 minutes. All right. Let me tell you something about reflections. This is the most effective and most difficult skill to practice in motivational interviewing. If you are in doubt what to do, reflect. If you want to test hypotheses, reflect. Why reflections are so important? In our normal life, when we talk to another person, under no stress, with no time constraints, absolutely normal situation. Even under those circumstances, there are at least 4 places to make a mistake. If I'm the speaker and you are the listener, what I said may not necessarily be what I meant to say. What you hear me saying may not be exactly what I said. What you think I meant by that may have nothing to do with what I meant, okay? The amount of mistakes, the likelihood of errors goes up exponentially when people are stressed, when people are constrained in terms of time. The amount of mistakes will go up significantly. So the reflections, that's exactly what it is. I'm putting a mirror in front of you. Here is what you just said, okay? One of the functions of reflections, we call it the accuracy. Just making sure that you understood the patient correctly. By doing that, we are sending the message to the patient, you are important. I am trying to understand what are you saying. It is important for you. I'm present here. So you're killing two birds with one stone. First, you're making sure that you understood the patient accurately. And secondly, the patient is getting the message that you're interested. You're not talking to your computer, you're talking to a person, to a human being in crisis. Folks, you will be working for the rest of your life with people in crisis, because if a patient comes to your office, by default, it means that this person is in crisis, okay? If they're not in crisis, why would they come to see you, okay? When people are in crisis, they have all sorts of hesitations, problems, emotions, everything that you can think of. So reflecting is a wonderful way to make sure that you understood the patient correctly and showing the sign that you are actually interested. Why is the emphasis on reflections rather than questions? First, because the research says, tons of research for the last 35, 40 years, that people tend to respond and talk more responding to reflections rather than questions. And there is a reason for that. Secondly, patients will get this message, get the feeling that they're important, and you're trying to understand what exactly they're struggling with. And again, lots of science, lots of studies show that patients actually tend to lie less, responding to reflections rather than questions. By lying, let's make sure you have clear understanding. Our patients are not liars, but patients sometimes give information that is not exactly truthful. And there is a reason for them. The easiest way to call them liars, but there is a reason for that. I'm not asking you to answer. Just think about it. Has it ever happened to you to lie your dentist about flossing? Okay. Just think about it. People, by doing that, by giving information that is not very truthful or not exactly accurate, this is a very powerful protective mechanism to avoid certain things. For instance, being lectured about things that people already know. So people tend to give more accurate information responding to reflections rather than questions. Reflections never sound like questions. In most languages in the world, your sentence will sound like a question if the tone of your voice goes up at the end of the sentence. And your sentence will sound more like a statement if the tone of your voice goes down at the end of the sentence. You will be surprised how different is the reading by the recipient of your message. I can illustrate it right away. Will you help me? These are two of my POM group students. Please say, I want a divorce. Say it. Let's imagine you're in a counseling session. Just imagine. It might happen. Say it. You want a divorce? Please say the same. I want a divorce. So you want a divorce. How do they make you feel responding, you want a divorce? Making fun, I'm attacking, second-guessing, questioning. And you're ready to fight with me, right? You're in a boxing posture already. This is the last thing I want to see in a patient. I don't want to wrestle with patients. This is not my job. But by doing that, you want a divorce? Now, all of your defensiveness are right there. How did I make you feel when I responded, so you want a divorce? Okay. I'm trying to understand and accepting what you said without passing any judgment. Okay. The words are exactly the same. The sequence of the words is exactly the same. The only thing I've changed is the tone of my voice at the end, and you see there are two different readings. Also, there are different types of reflections. There's simple reflection, just responding back to what the person said, making sure you understood correctly. But there is a number of so-called complex reflections. Complex reflections, I'm not responding exactly the way what the person said. I'm adding a meaning. I'm adding something. And the reason for me to do that is to test a hypothesis. Like you have 15 keys, you have 15 doors, you don't know which key opens what door, so you're trying, okay? At one point, the door will get open, but you don't know which key will do it. Example, I had a patient with whom I had a relationship. We worked with him for quite some time. So we already had some relationship built, professional relationship built. He came to my office. He had severe alcohol use disorder. He came to my office one day. We had a conversation. This was his relapse again. And he said the following. I quote him. He said, "Doc, I want to be honest with you. Yeah, I know it would be nice to wake up sober one morning, but frankly, let me tell you, I don't think I can do it. Because all my friends drink. These are the only people around me. I don't have anybody else. These are the closest people to me. We are friends for 40 years. They all drink, and frankly, I don't think I will be able to quit." Okay? That's what he said. What would be a simple reflection here without adding anything? Well, it seems like it's really difficult for you. Or it looks like your friends are quite important to you. Okay, I'm not adding anything. I'm just responding back with reflection that I did hear what the person is saying and I respect his opinion. What I did, I used a different type of reflection, a complex reflection, and I could afford it because we already had some established engagement with him. I said, you know what, I'm listening to what you said, and I'm getting an impression that your friends don't care about you. This is not what he said. Then he was quiet for maybe 10 seconds, which is a long time in a clinical session, and the next thing he said was, I've never thought of this that way. And for the next couple of weeks, we had a conversation about friendship, being lonely, how to interact with others, not about alcohol. He could have responded, this is not at all what I said. If that's the case, I would say, fine, I probably misunderstood you, help me understand it. And we'll continue the conversation. I tested the key, and it did not open the door. But when I tested the key, the door, And I told him that my impression is that your friends don't care about you. And he responded that he had never thought of it this way. That opened the door for a very meaningful conversation for the next couple of weeks and couple of months. Not about alcohol, about friendship, being lonely, and many other things. You have a patient who is actively using amphetamines. And in the clinical session, the patient says, that's not a problem for me. Amphetamines, other people use more than I do. My real problem, I want to get a PhD in neuroscience. Doesn't sound like a very realistic idea. Are you going to be sarcastic? Are you going to confront the patient? That will actually ruin everything that you just established, if you did establish anything. What I would do, I would use another type of reflection. We call it double-sided reflection, just building on the discrepancy by saying that's an interesting idea. So it looks like higher education is an important thing to you. So on one hand, you're still using amphetamines. On the other hand, you want to go after your PhD, which sounds like a good idea. How do you see these two things happening together? For most people, that will be difficult to do. You probably have some ideas how to continue using amphetamines and get your PhD. Just tell me more about it. It's interesting. You're facing an interesting dilemma. Okay? I'm not repeating exactly what the person said. I'm using a reflective statement to have this conversation to build a discrepancy. There are many other things I would be willing to show and share with you. There are many different types of reflection. Just do understand the difference between questioning people and reflecting on their statements. Okay. You remember in the definition of motivational interviewing, there is a word directive. What makes it directive? Motivational interviewing is not following the patient blindly wherever the patient wants to take you. No. You have a strategy in your mind. You have a strategy. And the strategy is you're listening very carefully. You're listening for some specific statements in what the patient said. The material that motivational interviewing works with is the ambivalence. The ambivalence has a verbal expression. In everything that the patients say, there are two parts. We call them change talk and sustain talk. Change talk is everything, every part of the patient's statement that resembles some movement toward change, at least potentially. Sustain talk is everything that the patient says in favor of not changing anything. Both are always present, but in different proportions. One of the skills that we need to master is listening very carefully. I'm listening for the change talk, and I'm listening for the change talk with the intent to reinforce it. Why? Because we know from multiple studies, from the science, lots of science, that the more the patient is talking about the possibility of change, the change hasn't happened yet, the possibility of change, even if it's a small piece, the more likely the change will happen. And we also know from lots of studies that the more more I talk about the necessity for change as a provider, the more I talk about change, it will make it less likely that the patient will consider change. It will be very likely that the patient will become very defensive. So, one of the things I need to train myself is to listen very carefully and separate change talk from sustain talk, because I don't ignore anything. I'm just not responding to sustain talk. I'm responding only to the change talk. You remember the statement from my patient. Yeah, I would like to wake up one day more sober in the morning, but you know what, I can't do it, blah, 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 blah. Was there any change talk in this statement? Yes, there was. He said, I would love to wake up sober in the morning. This is exactly the part of the statement I will go after. Have you seen people gold mining like this guy? Have you seen people like doing that? In the river, cold water, they have this, pan with the net underneath. They grab the sand from the bottom. They're looking for gold, right? They're paying attention to everything. They're not ignoring the sand, but they just let it go because this is not what they're after. They just let it go. They grab the sand from the bottom, no gold. Made a couple of steps left, right, grabbed again, No gold, let the scent go back. I'm still paying attention, but I don't need the scent. Then after a couple of trials, grabbed again, aha, ba-bam, I got a piece of gold. Small nugget. What does it tell me? It tells me don't move. Stay right here because I want more of it. Okay? I really want to make sure I explore this spot. That's exactly what we do in motivational interviewing. We train ourselves in very good reflective listening, and we are listening for specific things. We are not just listening to be good humans. You don't need me for that. You're already good humans. We are listening for specific things, specific beats of the statement by the patient. We call it change talk. And when I hear that, I really want to reinforce it. Unfortunately, folks, we are not very good in listening. We are very good in talking. This is the way we are conditioned since the childhood. It takes 2 years for a human being to start talking and then the rest of the life to shut up. That's unfortunately how we are conditioned. That's how so we need to train as professionals. We need to train ourselves how to separate one thing from another. Please watch this. It's very brief video. This is a horrible interaction. I just want you to see a small part of it.
As this provider becomes more and more confrontational in her warnings about tobacco use and her advice to quit smoking.
Okay, so I wrote a prescription for an antibiotic for Aiden that should help with the ear infection, but in looking through the chart, I mean, it seems like he's had 6 or 7 of these just in the past year or so.
Yeah.
That's really a big problem.
Yeah, it's pretty stressful for both of us. He gets really upset.
Well, one of the primary risk factors for multiple ear infections in kids is actually smoke exposure. Are you smoking?
Yeah, I do smoke, but I don't smoke around him. I try really hard not to smoke around him.
Well, the fact that he's having these ear infections is indicating to me that he is being exposed to smoke. And so what can you tell me about that?
I don't know. I mean, I try really hard not to smoke around him. I don't smoke in the car. When he's home, I go outside to smoke. I know it's bad, and I know it's bad for him, so I don't want him to be around it, so I try really hard.
I really need you to quit smoking, both for your health and for Aiden. Did you know smoking around your child is associated not only with ear infections, it could get to the point where you have to put tubes in his ears pretty shortly here, but also things like vitamin C deficiency, cavities, like dental cavities, behavior problems, asthma, other upper respiratory infections. It's really putting him at a lot of risk. In addition to that, kids of smokers end up smoking themselves. Do you want him to grow up to be a smoker?
No, but I don't smoke.
Okay, you would agree with me this is horrible. This is not the way to talk to a patient, particularly a patient who is that ambivalent. Now, here's what I want you to do. We will see...
As this provider becomes more and more
we will watch these two people discussing exactly the same issue. This time, the doctor will use a different strategy, but here's what I want you to do. Don't pay attention to the doctor. Don't pay attention to the doctor completely. Listen only to the mom's statement, to the patient's statements, okay? Listen very carefully. Now, I will ask you, please stand up. When you listen the statement from the patient, from the mom, when you hear something that you believe resembles a change talk, you will clap, okay? When you hear something that resembles sustained talk, meaning not changing anything, you will snap, and I will help you, okay? Did you get it? Pretty simple. I will help you. That will help you in kinesthetic way to start learning how to differentiate the two types of statements. Okay.
So I wrote a prescription for antibiotics for Aiden.
Okay.
I did want to talk to you, though. I'm a little bit concerned looking through his chart at how many ear infections he's had recently, and I noticed that you had checked the box that someone's smoking in the home, so I was wondering if you can tell me a little more about that.
Well, it's just me and him, and I do smoke. I try really hard not to smoke around him. But I've been smoking for 10 years, except when I was pregnant with him. But everything, it's so stressful being a single mom and having a full-time job. And so it's just, that's why I started smoking again.
You have a lot of things going on, and smoking's kind of a way to relax and de-stress.
Yes, yeah. Some people have a glass of wine, I have a cigarette.
Sure. And it sounds like you're trying not to smoke around him. Why did you make that decision?
I know it's not good for him. I mean, I've read those things about ear infections and asthma and stuff, but other kids have ear infections and their parents don't smoke.
So on the one hand, you're worried about how your smoking might be affecting him, and on the other hand, you're not so sure if it's really the smoking that's causing these problems.
Right, yeah. I mean, he doesn't have asthma. He hasn't had a lot of other problems that his other friends have. So, and I've thought about quitting before in the past, but I just don't see how it's possible right now.
What made you decide to quit smoking when you were pregnant?
Well, he was inside me and we were sharing everything, and I knew that he would get some of that, and I just didn't think I could live with myself if something happened to him.
Right now, though, it feels almost too difficult to even manage or even to try.
Yeah, exactly.
How were you successful when you quit before?
I don't know. I think about it now, I don't even know how I did it. I just did it. You know, I just couldn't imagine like him not being born or going into labor early and him having problems and stuff like that, all the stuff that they talk about with women who smoke. So that was just enough to say, okay, you know what, I'm not going to risk that. Mm-hmm. So
the risks were so scary then that you're able to stop. But
yeah.
They don't feel as scary to you now.
No, I mean, we're two separate people, and like I said, I try really hard not to smoke around him. I'm pretty good about that.
Okay.
I don't let other people smoke around him.
Okay. You see, when I told you what to listen for, and now you're a little bit better trained in this reflective listening for the change talk. You see, the mom gave to the physician change talk and sustained talk in every statement, in every sentence, or almost every sentence. The physician here is very strategic. She did not respond to the sustained talk. She keeps responding to the change talk only, and as a result, she's getting more change talk. And we know from research, many, many years, as I said, the more the patient is talking about the possibility of change, the more likely the change will happen. So when you work with patients with chronic conditions, let me tell you something, and I'm close to the end. My mom was diabetic. She was diagnosed with diabetes. I was already a doctor. And then her physician called me. He said, we cannot manage anymore with medication. We need to start insulin. My mom was professor of physics, very opinionated, very smart. And she said, absolutely not. I'm not doing that. I'm not, shooting insulin every day. No, I completely not. Okay? And she was very clear about this. Folks, I'm a trained psychiatrist with some experience. Believe me, I've made every mistake imaginable talking to my mom, saying, don't you understand that if you don't do that, here is what will happen? Folks, now retrospectively, years later, I'm thinking that every error I could have made, I've made it. Okay? The common sense, the impulse is understandable. This is probably the least effective strategy, trying to convince somebody. The situation has changed when I changed my strategy and I asked her, okay, it's up to you. At the end of the day, this is your life. It's not my life. But tell me, what is important for you? Oh, I want to be with my grandkids, with my kids. Okay, so it seems like grandkids are important to you. Of course, this is the meaning of my life. Okay, well, how do you see it happening? You're ignoring what the doctor says. Okay, you don't believe, she didn't believe that I'm a doctor to the end of her life. She couldn't appreciate that I'm a physician. I said, well, the doctor has an opinion, you have your opinion, and definitely your opinion is quite important for me. But if this is what you want to see your grandchildren growing up, how do you see these two things happening since you decided to ignore the doctor's suggestion? And that was the beginning of a conversation. Because instead of pushing her, and the only thing you will get in response, push back, it's a normal human reaction to push against something that pushes against you. It's a normal human response. And unfortunately, in life, we do it all the time. We are trying to convince other people they're wrong, and the only result of that, they will try to convince you that you are wrong and they're right. Now you're a wrestling competition. This is not a therapeutic process. I don't want to wrestle with my patients. I will get very tired by the end of the day, and it's not effective. Okay? So when you work with somebody who is very ambivalent, and as we said, the ambivalence is the material for motivational interviewing. Gradually, not immediately, gradually, you may see these things. The resistance will go down. The patient will stop discussing the problem and will start talking about the possible solutions. The patient will even maybe try to experiment. The patient can tell you, well, I didn't smoke for a whole week, but then I relapsed. I'm hopeless. Well, I respect your opinion that you're hopeless, but you have never, in the last 25 years, you have never had a smoke-free week. How did you do that? For most people, I've treated patients with nicotine dependence. It's difficult not to smoke for a whole week. How did you do that? I think it's a major success. How did you do it? Tell me more about it. Okay, I'm not arguing, I'm not judging, I'm not doing anything. I'm just talking to the patient, capitalizing on success, capitalizing on the strengths, and listening for the change talk to reinforce it because I really want more of it. Okay. Thank you. We have time for one more thing. Okay, got it. One more thing, folks. If we had a conversation about brain neurophysiology and how the dopamine transporter works in the brain, in the amygdala, that could be done in a cognitive way. I could give you a lecture how that works. I can do that. That would be sufficient. Motivational interviewing is the type of skill similar to if you want to learn how to play a musical instrument. I'm a professional jazz musician. I played jazz saxophone for many, many years. If you want to learn how to play saxophone, definitely I will need to give you some instructions to show you this instrument, to explain. You will need some instructions. Are you going to play after that? No. The next thing that needs to happen, I will give you a saxophone. You will start playing for me. I will give you some feedback. We will prevent bad habits from happening. And by doing that, you will become proficient very quickly. Okay? This is the type of skills in motivational interviewing this is how people learn it. A lecture like that just gives you some idea what it is not, and what are the elements of motivational interviewing. If you are interested in learning more, then we need to do a different type of education. This is what I do with preventive medicine residents. They work with the patient, I observe the interaction with the patient, give them feedback, we do it again and again and again, and that's like learning how to play tennis or play saxophone or do anything else practical. So I don't think you will be able to do motivational interviewing at the end of the lecture right now, but at least hopefully you will get some idea what it is and what it is not. Okay? Now, thank you. Questions? Okay, got it. Love you. Questions, comments, thoughts? You might have some questions, ideas. Please, we have, 6 more minutes. No thoughts? Yes, please. Good question. The question is, how often do I use this conversational strategy outside of my practice? Sometimes I do, but very rarely. My wife is a clinical psychologist, and she's a very well-trained clinical psychologist in private practice. When I start doing that, she said, oh, don't do this MI crap. All right? Sometimes, particularly when you, in real life, you meet somebody who is ready to fight with you, very argumentative, or somebody. The bottom line, and you want to avoid any kind of conflict, the bottom line is it would be very difficult to argue with me if I don't argue with you. You will survive 10 seconds, and then what? Okay? So if you remember that and suppress your impulse to argue back, and in clinical practice, by the way, it may happen, the impulse may happen when you hear a patient saying something that is totally inconsistent with your medical training, totally inconsistent with the science, and could be potentially detrimental for the patient's health, I do understand your impulse to start arguing to prove your point. Suppress the impulse. That's the difference between people at 7-Eleven and professionally trained physicians. Because people at 7-Eleven, they can afford to act on their impulses. You cannot. You need to act on your skills, and this is what we are doing here. Make sense? Wonderful question, by the way. Yes? Not really. Well, the patient has to have certain level of cognitive abilities to maintain a conversation. The important thing here is if you have a patient who is ambivalent, hesitant about something, this is the time to use motivational interviewing as a style using some of these skills. Yes? This is a wonderful question. What to do if the patient is not ambivalent? And we said that ambivalence is the material for MI. Make the patient ambivalent. And the way to do it, you can do it in 15 seconds by asking a simple question. You know what? It's interesting. I appreciate everything you said. If should one day you decide to quit smoking, what do you think your life will look like? By asking simple question, this simple question, I'm sending 3 messages. Should you decide, so you're the one who will decide. At some point, I'm not giving you any time frame, I'm not putting any limits. Should you decide one day, what do you think your life will look like? I'm making it hypothetical, okay? Just by asking this simple thing, you will make your patient ambivalent the next second. Okay? Now you have a material to work with. Did I answer your question?
Another round of applause for Dr. Case.
Thank you.
I'm sure Dr. K will hang around for a second or two.
I'm here, yeah, I'm here. Hi.
How are you?
All right.
I just
So
need to.
it's
I
your
just need to
lecture now?
I'm next.
Oh.
Yeah, I just need to.
Oh, I didn't eat your time. You have
No,
you
no, no,
still
no,
have
no.
a
You're
couple
good.
of minutes.
No, you're fine. Yeah, you're complete. You did not eat my time, and I'm glad I got to hear the end of it. That was perfect. It's worked so well. I am about to be very argumentative. I am in a seriously argumentative mood. Ah. Did he project from his computer? Yeah, room PC. Here we go. Nope. Yep. Nope. Yep. Got it. Nope. I'm in the wrong course. I am in the wrong course. Is there, so we're going to sit in front here. Is there a way to